welcome to another session of clinical pharmacology and drug therapy. I am Dr. Khalid Hassan, Associate Professor of Clinical Pharmacology and Drug Therapy. Today we are going to speak about anti-cancer drugs as a part of chemotherapeutic medications. We are going to maybe mention a brief introduction. Then we talk about the leading cause of death from cancer. We are going to speak about the most common type of cancer. We have main type of cancer, like we have solid tumor, and then we have hematologic malignancies. Moving to the characteristic of malignant and neoplastic cells. Then moving to the genetic disorders in cancer cells. Then we are going to speak about positive regulator, negative regulator for the cancer cells. We have to mention the cancer cell cycle kinetic. Here we are going to speak about cell cycle specific drugs and cell cycle non-specific drugs. So we have two groups of medication belong to according to the cell cycle. Moving to the goal of treatment of cancer, so could be cure, could be prolonged survive, improve quality of life, prevent complications. What type of treatment available for cancer? We start with we have several types, but we are going to focus on something related to the clinical pharmacology and drug therapy. But we have other approaches, other methods such as surgery, radiotherapy, chemotherapy, hormone therapy, immunotherapy, stem cell transplant, biological factors or biological or targeted therapy. So we have so many approaches there. Briefly, we are going to discuss the resistance to the anti-cancer drugs. If anything happened on the DNA or in the target enzyme or in the activation of the product or inactivation of anti-cancer drug. Also, we are going to speak about combination therapy. Sometimes we need combination therapy to enhance the drug activity and to decrease drug resistance. So combination therapy in anti-cancer drug could be important to reduce highest effective and reduce toxicity if we compare with monotherapy. To talk about the principles of combination therapy, then we have some treatment protocols, moving to the rescue therapy, then we move to the individual drugs. As an overview, cancer is uninhibited new growth of a cell or a tissue. Cancer is considered like a second leading cause of death in the United States and exceeded by only heart disease. In the United States, 2019, according to the CDC, it's mentioned that about 1,700,000 new cancer cases was reported, and around 600,000 people died from cancer. In Maryland, 2019, more than 33,000 cancer cases were reported. As you can see from this table here, like on this slide, the cancer considered like second leading cause of death. So if you click on the slide here, so you can see the information here, cancer leading cause of cancer, and coming from the CDC, Centers for Disease Control and Prevention, cancer considered like the second leading cause of death. Okay, the most common type of cancers, we have breast cancer, lung cancer, prostate, colon cancer, melanoma, bladder cancer, lymphoma, non-Hodgkin lymphoma, kidney cancer, endometrial cancer, leukemia, pancreatic cell, thyroid, and liver disease. So we have category for cancer. We have several classification. Major type of cancer, it has been classified as solid tumor or hematologic tumor. Solid tumor begin as abnormal tissue and growth spread through the tissues. And the most popular type of these solid tumor, lung cancer, colon cancer, breast cancer, prostate cancer. Hematologic malignancy arises from the bone marrow or lymph node and produce large quantities of abnormal blood cells. The most maybe popular type of hematologic malignancy, we have leukemia, lymphoma, multiple myeloma. Cancer results from transformation of normal blood cells into the malignant neoplastic cells. Characteristic of these malignant neoplastic cells characteristic include loss of normal function. We call this one dedifferentiation, uncontrolled cell division, invasiveness, and metastasis or metastasis. So invasiveness of cancer cells spread into the surrounding tissues. Okay, so the invasiveness of cancer cell may be defined as spreading into the surrounding tissue. Metastasis of cancer cell, the cancer cell spread through the blood and lymphatic system. So for the both of this aspect in invasiveness and metastasis of cancer cell depends on the expression of growth factors, and the growth factors, we have more than 60 growth factors, and this will lead to the promote angiogenesis. The definition for angiogenesis means formation of new blood vessels that provide a blood supply to the tumor. So this is new blood vessels provide blood supply to the tumor. According to the American Heart Association, we can click on this one here and look on what we have. I'll bring this to the discussion here. And regenerative angiogenesis. And you can see here, if you click on this image here, you can see the angiogenesis, the new formation of blood vessels. So we have healthy angiogenesis, therapeutic angiogenesis, unhealthy angiogenesis. This is what we're talking about here, whether this is unhealthy in the metastasis or in the invasive. Okay. Now moving to the genetic of cancer, the genetic basis of cancer. So what we have here, we have in the human body, we have something called oncogene. Then we have some genes responsible for suppression or suppress the tumor. So we have some oncogene. If this oncogene activated, the result will be causing a cancer. So oncogene responsible for cell proliferation. Mutation in this oncogene, this will lead to the uncontrolled cell proliferation. What type of gene we have there? We have gene called EGFR, we have HER, ARB2, and MET. Okay, this one here we have the abbreviation for each one. For example, EGFR, epidermal growth factors receptor. We have HER2, we have human epidermal growth factor 2, MET, mesenchymal epithelial transition, and we have breast cancer, BRCA1. Regarding to the gene suppressing tumor, so if any mutation happen on these genes, the result will be uncontrolled cell division. So these genes, two important genes, B53 gene and the BRCA1 and 2 gene, and this is responsible for the suppress the cancer, prevent the cancer. This is responsible for repair DNA damage. So if any damage happened, these two genes responsible for reparation. So repair the defect, repair abnormalities, two genes, B53 and BRCA2. Okay, regarding the genetic of cancer, we have two types of genes in our body. We have oncogenes, and this genes, if any mutation happen in this gene, this will lead to the uncontrolled. This will lead to the uncontrolled. Let me go back. This will lead to the uncontrolled cell proliferation. Example for the oncogene, we have EGFR, HER2, ARB2, and MET. And the abbreviation for these genes is listed here in that small table on the top. What we have here, EGFR, HER, MET, and BRCA for breast cancer gene. Then we have EGFR, epidermal growth factors, human epidermal growth factors, so the abbreviation will be there. So these genes, if any mutation happen, this will lead to the breast cancer, lung cancer, or pancreatic cancer. So we have oncogene, and this oncogene responsible for if any mutation happens in the genes, this will lead to different type of cancer. We have another type of gene. These genes responsible for suppression of a tumor. So this gene responsible for repair of DNA damage. So if any mutation happens in these genes, this will lead to the uncontrolled cell division. So what happened here? We have the cell division here, we have cell proliferation here. So we talk about cell division, we have two main genes. We have B53 genes. If any mutation happened, this will be responsible for different type or variety of type of cancer. If any mutation happened on the BRCA, this gene is responsible for breast cancer gene, BRCA 1 and 2 gene, this will lead to the breast cancer or ovarian cancer. So we have two set of genes, one of them responsible for proliferation and another one responsible for repair DNA. So which one is responsible for the cell proliferation and which one is responsible for cell division? And if the mutation happens, this will lead to the cancer, different type of cancer. Okay, so again, we have some cell cycle regulator. For example, here we have some positive regulator. We have cyclin, CDK, stands for cyclin dependent kinase. Then we have growth factor. Then we have other maybe genes responsible for regulator. And they said if any genetic mutation happened in this positive regulator, the genetic mutation lead to activate these positive regulator. So if any mutation happened and activate these gene modulator, the result will be convert the proto-oncogene to oncogene, and this lead to the cancer. Okay, moving to the next one. This one is responsible type of gene responsible for inhibit cancer. So we have B53, BRCA1, BRCA2. This type of gene responsible for inhibition of cancer. So if you have mutation in these genes, this will lead to the inactivate this negative regulator. So we have positive regulator, and then we have negative regulator. If you activate the positive regulator, this will lead to the cancer. We have negative regulator responsible for inhibition of cancer. If you inactivate this gene, the result will be lead to the maybe cancer occur. Okay, regarding cancer cell cycle kinetic, this one here remind us with the pharmacokinetic. We have two main type of kinetic. We have maybe first division called cell cycle specific drugs. So this group of medications, chemotherapeutic drugs, present their action selectively on the cell cycle. So we have cell cycle starts from S, G1, G2, and so on. And so cell cycle specific affect the cells during the activity. Cell cycle non-specific could be during the active, during both active, okay, both during cycling or during resting cells. And here we talk about G0. Okay. Okay. Let me click on this link here, show what I have. Okay, this is what I need to show you. Okay, let me make it like full screen. So you can see here we have cell cycle, non-specific agent, then we have cell cycle specific agent. So here maybe the student recommend to review this slide here for cell cycle non-specific agent. For example, we have cyclophosphamide, chloramphenicol, cisplatin, some antibiotic, non-specific, non-specific, alkylating agent, non-specific. What about cell cycle specific agents? Affect mainly the active cells. We have folate and analogs such as methotrexate, purine analog, mercaptopurine. We have pyrimidine analogs such as fluorouracil. Then we have topoisomerase like etoposide and topotecan. Then we have cytotoxic antibiotics such as bleomycin, antibiotic product, vincristine, vinblastine, paclitaxel. So we have a group of medication. Here we need you to remember we have too many groups. The first group considered like cell cycle non-specific, such as cyclophosphamide, carmostins, cisplatin, daunorubicin, doxorubicin, and dactynomycin. Back to the slide again. So we have we need to remember the category for the specific and non-specific drugs. Okay, what is the goal of cancer treatment? The goal of cancer treatment, number one, obtain a cure, prolong survival, improve quality of life, preventing complications, and palliating symptoms. How we can treat cancer? We have several options. The highlight one is like belong to the pharmacotherapy, but could be surgery, radiotherapy, hyperthermia, photodynamic, but the important one for the pharmacotherapy, chemotherapy, hormone therapy, immune therapy or immunotherapy, biological factors. So this one will be addressed in this lecture today. When you prescribe medication to your patient, chemotherapy, anti-cancer drugs, sometimes the cancer resists the medication. So drug resistance is a major problem with the cancer chemotherapy. This may be warrant for the combination treatment. This is give warranty to the for combination to use multiple medication to maybe recover or to induce remission from cancer. So here the cancer cell may develop the resistance toward the drug. We have several mechanism of resistance to the anti-cancer drugs. Number one, the cancer cells increase DNA, produce or demonstrate DNA repair. The cancer drug the cancer cell may lead to the formation of trapping agents, a change in the target enzyme on the cell, for example, inside or outside the cell surface or inside the cell surface, inside the like intracellular or in the nucleus. Decreased activation of prodrugs. Sometimes the anti-cancer drugs could be proactive. Prodrugs should be activated, and the cell developed a mechanism to decrease activation of these prodrugs. Inactivation of anti-cancer drugs, such as we have several examples here for each mechanism, and decrease drug accumulation. So all these could be mechanism that explain how the cancer resists drug therapy. Increase DNA repair, formation of trapping agent, changing in target enzyme, decrease activation of prodrug, inactivate anti-cancer drugs, or decrease drug accumulation. So we have some examples here. Okay, normally in the treatment of cancer, we use a combination of therapy, and the purpose of combination of therapy to enhance efficacy of medication, to enhance efficacy. Okay, the enhanced efficacy compared with the monotherapy. When you use a combination therapy, this will lead to the synergistic or additive effect. This is similar what we have in the antibiotic. When you use 2 antibiotic or 3 to treat infections. When you use a combination therapy, this combination therapy lead to the decrease or reduce drug resistance and provide the therapeutic effect benefit also for the cancer cells to kill the cancer cells or remove it. Okay, the combination therapy, we have principle for the combination therapy. Number one, what is the purpose here? Each drug should be active when used alone against the particular cancer. So we don't use something inactive. Each drug should be active treatment for particular cancer. The drug should have different mechanism of action. So this one very important. We don't need to use two medication belong to the same mechanism of action. We don't prefer to use the same mechanism of action. It should be different mechanism of action. This is very important. This remind me with, for example, amoxicillin plus gentamicin. When you use it as the antibacterial, this one, amoxicillin, inhibit cell wall. Okay, and the gentamicin work on the inhibition of RNA. So, or we call this one protein inhibition. And this one affect the inside the cell. So you can see here the amoxicillin destroy the cell wall. Okay, amoxicillin destroy the cell wall. And the gentamicin affect the RNA and the cells. And this one represent the synergistic effect. So the reason, if you can go back there, so we need this maybe is a combination to be under the synergistic or additive manner. The same situation will be applied for the similar to what we have in the bacteria. For such example, amoxicillin and gentamicin. So we don't prefer to use, for example, if the patients are from infections, for example, we don't prefer to use ampicillin plus like penicillin G. Okay, this one is like, it's not acceptable because both medication work on the same target. Should be different mechanism of action. So when you use anti-cancer drugs, the anti-cancer drug should be on different mechanism of action. Okay, cross resistance between drugs should be minimal. So we, for example, we need to look on different different mechanism of resistance, different toxic effect. This one very important, different toxic effect. So when you use medication, it's not supposed to for example, if the medication causes nephrotoxicity, the other medication should not cause nephrotoxicity, because if the two medication cause the nephrotoxicity, the situation will be aggravate the side effects here. So we don't recommend both medication used together and causing the same toxicity. Treatment protocol. Here we have many cancer treatment protocol have been developed and applicable for to particular neoplastic state. We have acronym for that. For example, we have RSHOP. RSHOP, this one stands for the rituximab, cyclophosphamide, hydroxydonoropsin, oncovine, the brand name for the vincristine. Then we have prednisone. And you remember prednisone belongs to the corticosteroids. So for the RSHOP protocol of treatment, this protocol used for patients from non-Hodgkin lymphoma, and we can have maybe the list of this medication: rituximab, cyclophosphamide, hydroxydonoropsin, and oncovine, and finally we have prednisone. So for any, if we need any more information about this one, we can review the textbook. We have list of protocol therapy for each type of cancer. Okay, so the slide here talk about rescue therapy. I like this one here because this slide tried to focus on the management of adverse drug reaction. So the patient suffer from cancer, you place the patient on anti-cancer medication, the patient come back to the clinic suffer from side effect of this medication. I will give you some example here. What happened? If the patient come to the clinic suffer from folic acid deficiency, we can prescribe leucovorin Leucovorin is indicated for high-dose methotrexate. We know that methotrexate causes deficiency of folic acid. So methotrexate causes deficiency of folic acid. So we need to prescribe folic acid to your patient, and the medication name leucovorin, as it's available here for patient treated with methotrexate. Patient treated with cyclophosphamide. The patient at risk of developing of hemorrhagic cystitis, inflammation in the bladder, and the patient start urinating blood in the urine. And in this patient, it was warrant for that to start treatment with a medication called Mesna. You can see the Mesna here, and the Mesna is like abbreviation for or stands for mercaptoethan sulfonate. So this one, we are going to speak about what is the mechanism, why cyclophosphamide cause hemorrhagic cystitis. But if hemorrhagic cystitis happened, the medication here, the management will be prescribing Mesna, which means reduced incidence of hemorrhagic cystitis during treatment with cyclophosphamide. Filgrastim here, this medication considered like myeloid growth factors or granulocyte colony stimulating factors. So this medication stimulate the bone marrow to produce the granulocyte. So granulocyte colony stimulating factor. Granulocyte colony stimulating factor, GCSF, typically used for prophylactic to reduce risk of neutropenia. Neutropenia means decreased number of white blood cells. Okay. So we have all the medication there, and we have 3 medication belong to the rescue therapy. Okay, let us continue our lecture about anti-cancer drugs. Now we go to the classification. If I click on this link here, so I will go from there and start talking about the cancer treatment. So we have, as you can see, we have group of medication, antimetabolite, alkylating agent, antibiotic, cytotoxic drugs. So alkylating agent, for example, and microtubules inhibitors. Moving to the medication, the most important topic in anti-cancer drugs, the common adverse effect. So you can see here regarding the common adverse effect, you can see what we have: nausea and vomiting. Then we have extravasation and tissue necrosis, bone marrow suppression, embedded wound healing, loss of hair, alopecia. Patient may suffer from gastrointestinal epithelial damage, mucositis, hepatotoxicity, infertility, teratogenic, second malignancy, infection. All these considered like general side effect. Could any cancer drug cause this side effect? We have some specific selective side effects, such as bladder toxicity occurred by cyclophosphamide. We have cardiotoxicity induced by doxorubicin. Then we have pulmonary fibrosis induced by bleomycin. So for this reason here, we need you to remember bladder toxicity linked to the cyclophosphamide, cardiotoxicity, doxorubicin, and pulmonary fibrosis linked to the bleomycin, induced by bleomycin. Okay, for the nausea and vomiting, this is the most popular side effect. We can treat patient with, for example, metoclopramide, or ondansetron, we can prescribe anti-anxiety drugs such as diazepam or cortisone. So we have maybe a list of medication could be prescribed to treat patients who suffer from nausea and vomiting. Okay. Adverse effect for cytotoxic chemotherapy could be immediate effect, could be delayed effect. Immediate effect, the patient may suffer from nausea and vomiting, such as cisplatin and cyclophosphamide. Drug extravasation, when the drug may be leaking outside the vein, such as vinca alkaloid, doxorubicin, and anthracycline, the group of anti-cancer drug, one of these groups, medication named doxorubicin. So finca alkaloid such as vincristine, finblastin, delayed late effect. Patient after start treatment after maybe 1, 2, or 3 months may suffer from bone marrow suppression, infection, alopecia, drug-specific organ toxicity. For example, bleomycin may cause cardiotoxicity. We have psychiatric cognitive morbidity, teratogenic if the medication used during pregnancy, infertility, gonadal fever, and development of secondary cancer. So we have list of adverse effects related to the cancer chemotherapy. Okay, again, discussing the adverse effect. We already covered all these topics there. Okay, we have the case here. 59 old man undergoing ABVD chemotherapy for Hodgkin lymphoma arrived to the fourth cycle of a planned 6 cycles, reporting recently developing cough and mild sensation of restlessness that began a week ago. Which of the following frequently linked to the pulmonary toxicity? Finblastin, bleomycin, doxorubicin, or cyclophosphamide, or adriamycin. So pulmonary toxicity. Let us go back, me and you together, and show you which one maybe belong to the pulmonary toxicity. Anything in this slide? Okay, which one is belong to the pulmonary toxicity? Bleomycin. So the correct answer should be bleomycin, associated with the pulmonary toxicity. Antimetabolites. So the first group of medication we are going to discuss it here, antimetabolites, structurally related to the endogenous compound. We have in our body, we have a compound called folic acid, purine antagonist, and pyrimidine agent. So we have medication antagonize the action of these endogenous substances. We have folic acid, we are going to use antagonist of folic acid. We have purine, we are going to use antagonist for this purine, or to antagonize this purine. We have pyrimidine, we try to antagonize the pyrimidine action. Here we need to remember the group of medication. For example, which of the following medication inhibit folic acid? So we have methotrexate. Which of the following medication considered like inhibitory of or like block purine target? We have 6-mercaptopurine. From the name, we have 6-mercaptopurine. Then we have thioguanine. Pyrimidine antagonist. Okay, pyrimidine. We have fluorouracil, cytarabine, and gemcitabine. And this medication considered like cell cycle specific drugs. So to act primarily on the S phase of the cell cycle. So I will repeat it here. We have folic acid antagonist, we have purine antagonist, pyrimidine antagonist, then we have pyrimidine antagonist. Folic acid, purine, pyrimidine. So here we need to link the medication name. Methotrexate antagonist folic acid. Mercaptopurine antagonist purine. Fluorouracil antagonist pyrimidine or pyrimidine. Okay, start with the first medication, methotrexate. Methotrexate, from the name, is considered like antifolate. Methotrexate is structurally related to the folic acid and work as antagonist for folic acid. Methotrexate inhibit the hydrofolate reductase. Methotrexate inhibit enzyme called reductase, the hydrofolate reductase. Methotrexate inhibit the hydrofolate reductase. What enzyme will be inhibited by reductase? By methotrexate. The hydrofolate reductase will be inhibited by methotrexate, and this will lead to the inhibit synthesis of DNA and lead to the cell death. So here we have the consequences. Methotrexate inhibit the hydrofolate reductase, which is essential for the DNA synthesis. Methotrexate anti-cancer medication used for leukemia, lymphoma, bladder cancer with the large doses. Okay, we have other uses such as psoriasis, rheumatoid arthritis, Crohn's disease with a low effective dose. So here we have large dose, low effective dose, large dose as anti-cancer, small dose for psoriasis, rheumatoid arthritis, Crohn's disease. Adverse drug reactions, this medication cause bone marrow suppression, gastrointestinal mucositis, hepatotoxicity, teratogenic. This medication, because this medication inhibits folic acid, if the patient takes this medication, the patient may suffer from megaloblastic anemia due to the deficiency of folic acid. I will clean this one. I will say deficiency of folic acid. Therefore, the patient suffers from megaloblastic anemia, mucosal ulceration. Toxic of on the can be the megaloblastic anemia can be corrected by using like rescue therapy such as leucovorin. Leucovorin considered like folinic acid, so it's kind of folic type folinic acid. The generic name, scientific name leucovorin, and this is prescribed to correct the megaloblastic anemia or to prevent megaloblastic anemia during treatment. Okay, if you prescribe if you go to the website, okay. I've tried to find the right mechanism of action. I shared with you. Okay, I will go with this one, for example, here, or we can go to the textbook. We have it there in the textbook. That would be great for folic acid and methotrexate. I will show you what we have. Okay, I think here we'll be good to share with you what happened with methotrexate. Here you can see the effect of methotrexate. Methotrexate inhibits dihydrofolate reductase in two places, dihydrofolate reductase, and prevent synthesis of folic acid. So in the cancer cell, inhibit dihydrofolate reductase, okay, and prevent folic acid synthesis, prevent converting of dihydrofolate to the tetrahydrofolate, and this one responsible for synthesis of amino acid adenine, guanine, thymidine, methionine. All these considered like important substance for the DNA and RNA. So and we have maybe the most important side effect called megaloblastic anemia. So what we have here, highlight. So we need you to remember this one here. Highlight this one is very important. Megaloblastic anemia. How to treat the patient? That we can treat the patient with leucovorin to prevent with the leucovorin to prevent the megaloblastic anemia. Okay, move to the next slide. Okay, we're done with the methotrexate. Moving to the 6-mercaptopurine. 6-mercaptopurine work by interfering with the purine nucleotide adenine guanine synthesis, result in inhibition of RNA, DNA, and tumor cell death. So the main mechanism of action, inhibition of DNA, RNA by interact with the purine nucleotide adenine. 6-mercaptopurine cause bone marrow suppression. Most of the anti-cancer drugs cause bone marrow suppression. Hepatotoxicity, teratogenic during pregnancy is considered like contraindication during pregnancy. We need a TMPT enzyme to convert 6-mercaptopurine to the non-toxic compound. But they found here we have some individuals suffer from genetic deficiency of TMPT, stand for thiopurine S-methyltransferase. This is enzyme transferase, S-methyltransferase. This is enzyme responsible for metabolism of 6-mercaptopurine to the non-toxic compound. We have some individuals suffer from genetic deficiency. Therefore, these individuals they will suffer from accumulate level of 6-mercaptopurine in the blood, and patient may suffer from bone marrow suppression, hepatotoxicity, and teratogenic. Here I would like to click on this link here and show you what we have for the 6-mercaptopurine. This is article published about 6-mercaptopurine, and we are going to focus on the how the medication work. So I would like to mention only the picture here, or the image, the figure from 6-mercaptopurine proposed mechanism of actions. You can see here we have 6-mercaptopurine and we have enzyme responsible for the 6-mercaptopurine. So when you have 6-mercaptopurine, we have enzyme S-methyltransferase responsible for conversion of 6-mercaptopurine to the 6-MMP, which means inactive compound. So in this case, this presents us how this medication metabolite in our system or in our body. So here we have some people who suffer from genetic deficiency in this enzyme, and this will lead to accumulate this enzyme and lead to the toxic effect. Okay, moving to that. So we already discussed methotrexate, 6-mercaptopurine. Next agent will be alkylating agent. We have a group of medication, nitrogen mustard. Then we have nitrogen mustard. We have nitrosourea, platinum compound, and we have other, but we highlight the most important one. So what we have: chlorambucil, cyclophosphamide, phosphomide. Then we have carmostine, nitrosourea, platinum. We have cisplatin, dacarbazine. We are going to discuss only two medications in this group, alkylating agent. Two medications, cyclophosphamide and cisplatin. How this medication work? This group of medication induce or make DNA cross-linking, bind to the DNA and damage the DNA, lead to the cell death. And for this reason, this group of medication considered like cell cycle non-specific medication. We don't have any specificity here. Could be in the G0 or G1 or G2 on the or S phase. If you click on this link here and try to give you some information here. Okay, now you can see we have alkylating agent bind to the guanine, cytosine, and as cross-linking there. So you can see the information. It's like coming from article published. Okay, so alkylating agent, cyclophosphamide, cisplatin. That's the question now. What is the mechanism of action of cyclophosphamide? Cyclophosphamide causes DNA cross-linking. This will lead to the damage and cell death. And cyclophosphamide considered like cell cycle non-specific drugs. Okay, cyclophosphamide prodrug should be activated by the liver enzyme B450. Cyclophosphamide you consider like anti-cancer drugs and could be used for immunosuppressant for the patients from rheumatoid arthritis or systemic lupus erythematosus. So please remember this prodrug need to be activated. Anti-cancer drug for leukemia, lymphoma, breast or ovarian cancer. We use it for rheumatoid arthritis or SLE. Patient may suffer from bone marrow suppression, GI mucositis, hepatotoxicity, teratogenic. But the hallmark for the cyclophosphamide, we have patient come to the clinic suffer from hemorrhagic cystitis, which caused by a metabolite called acrolein. Acrolein is a toxic metabolite, and for this reason we have antidote or like medication bind and inactivate or maybe prevent from the toxicity of acrolein. This medication called MESNA, and MESNA stands for the mercaptoethane sulfonate. This is a MESNA here. So the MESNA will be the rescue therapy for the cyclophosphamide. Okay, the question now, what is the rescue therapy for the methotrexate? Question mark. I will leave it for you. Okay, moving to the next. Cyclophosphamide, we have another group of medication in the market. We have it efosfamide, we have cyclophosphamide, efosfamide. What are the differences? These drugs are very closely related to each other in the primary mechanism of action and toxicity. What they found here, cyclophosphamide available oral and available IV. On the other hand, phosphomide available IV only. Unique toxicity for both drug hemorrhagic cystitis can lead to the fibrosis of the bladder toxicity related to the acrolein. This is a toxic compound, acrolein. For this reason, we use mesna. Here, we recommend use adequate hydration as well as IV injection of mesna, which stands for the mercaptoethane sulfonate sodium, which neutralize the toxic metabolite and minimize the toxicity. So cyclophosphamide and efosfamide is very similar to each other, but the efosfamide IV only, but cyclophosphamide IV plus oral product available for the clinical use. Okay, so we're done with the cyclophosphamide. Now with the first one was methotrexate. Okay, what is the second medication? First medication, methotrexate. The second, mercaptopurine. Then we have cyclophosphamide. Moving to the cisplatin now. Cisplatin contains like central platinum ions. This medication, when you prescribe it, the medication will be concentrated in genitourinary system. For this reason, we use it for cancer arise in the genitourinary system, such as testicular cancer, bladder cancer, ovarian cancer. This medication may cause bone marrow suppression, bone marrow depression, hepatotoxicity, alopecia, severe nausea and vomiting, cisplatin, severe nausea and vomiting, nephrotoxicity, ototoxicity such as hearing loss, and peripheral neuropathy. And you can see here we have so many side effects, severe side effects coming from cisplatin. The suppression of bone marrow, hepatotoxicity, alopecia, nausea, vomiting, nephrotoxicity, ototoxicity, peripheral neuropathy. So we have a lot of side effects coming from the cisplatin. Okay, done with the cisplatin. Moving to the cytotoxic antibiotic, we have doxorubicin, we have bleomycin, and miliomycin. Doxorubicin inhibit DNA gerase, this enzyme, inhibit DNA gerase and lead to inhibition of DNA RNA synthesis. The hallmark, maybe the most important side effect for this medication, cardiotoxicity. Which of the following anti-cancer drug associated with the cardiotoxicity? Doxorubicin. Which of these medication anti-cancer drug associated with the pulmonary fibrosis? Bleomycin. Which of these medication mainly associated with the nephrotoxicity? And it's like miliomycin. So we have a list of medication. We need you to remember the name and the major side effect from each medication. Doxorubicin, cardiotoxicity. Bleomycin, we have bleomycin, pulmonary. We have miliomycin, we have nephrotoxicity. Okay, moving to the group of medication inhibit microtubules inside the cells. Microtubule inside the cells. We are going to see the link here and try to understand what that means for us, microtubules. Okay, let me click on this link and try to understand what we have there. Okay, this is from the website. We try to demonstrate what we have in the website for microtubule. Okay, you can see here the normal cells, and then we have microtubules. You can see when we prescribe finca alkaloid, such as fincrestin, finblastin, what happened to the microtubules here? So we have maybe destruction, deformation of microtubules will end up with a cell death. So dissolution of the meiotic spindle lead to the cell death. So normally we have normal function of the meiotic spindle and lead to the division of the cells. This group of medication inhibit the mitotic spindle. So the group of medication here, how this medication work, we have two main medication, fincrestin, we have fincrestin and phenblastin. This medication bind to the microtubules, mitotic spindle, and inhibit this mitotic spindle, lead to the prevent of cell division. This is cell cycle specific. Okay, and we maybe demonstrate the effect on the mitotic spindle. The question, which of these anti-cancer drugs bind to the microtubules and inhibit mitotic spindle? Okay, we have fincrestin, phenblastin. Moving to the adverse effect, we have fincrestin, phenblastin. Fincrestin cause myelosuppression, bone marrow suppression. Fincrestin cause peripheral myopathy. Phenblastin cause bone marrow suppression and neurotoxicity. But we need to look on the severity of side effects. For example, fincrestin mainly affect the central nervous system. Okay, mainly affects the central nervous system by causing peripheral neuropathy. So this one we can type it there like 3 plus or 4 plus about peripheral neuropathy. Fincrestin, central nervous system, peripheral neuropathy. With the fincrestin we have C. With the central nervous system we have C. Fincrestin cause CNS toxicity, mainly peripheral neuropathy, and we have only 1 plus for the or minus for the myelosuppression. Phenblastin. When we talk about phenblastin, we have bone marrow. This one I will put there 3 plus. Okay, and less toxic. If you talk about neurotoxicity, it's only 1 plus. So now we have a group of medication. Fincrestin cause peripheral neuropathy. Phenblastin mainly cause bone marrow suppression. The important issue, this medication should administer injection, IV or IM, injectable medication. And if this medication given in mistake intrathecally, this will lead to the death. Therefore, a special precaution should be in place for the administration. So it should not be administered, this medication should not be administered intrathecally. Intrathecally means directly to the central nervous system through the subarachnoid space. Okay, moving to the next group of medication belong to the cell microtubules. Okay, so what we have here, as you can see, we have cell microtubule inhibitors. We have paclitaxel, belong to the group of medication called Texan, and the Texan derived from the natural occurring compound found in the bark of the Pacific tree. And paclitaxel mainly used for patients from breast cancer and for ovarian cancer. Paclitaxel 40 to 60% of patients suffer from peripheral neuropathy due to the paclitaxel treatment. Paclitaxel may cause hepatotoxicity, bone marrow depression, alopecia. Okay, so we're done with the microtubules. We discussed 3 medication, fincrestin, phenblastin, and we discussed paclitaxel. For the hormone antagonists are used to treat a hormone-dependent tumor. So we have some cancers depends on the hormones, such as breast cancer mainly depends on the estrogen. Then we have prostate mainly depends on the androgen. And we talk about prostate mainly depends on the estrogen. So we try to use something like anti-estrogen or anti-androgen. So we have 2 groups of medication, depends on the situation. We're going to discuss the anti-estrogen and anti-progestin. So what we have here, we start with anti-androgen and anti-estrogen. For anti-estrogen, we have tamoxifen, then we have aromatase inhibitor, anastrozole, letrozole. Anti-androgen, we have flutamide, piclotamide, cyproterone, and more on this list. Okay, for anti-estrogen, what we have here, we have tamoxifen. Tamoxifen considered like estrogen antagonist on the breast. So antagonist on the breast. They found tamoxifen considered like agonist on the bone, and uterus. On the bone, that will be great, will be building the bone, and on the uterus, increased risk of cancer. So we don't prefer to use this medication for women has a history of cancer, for example. Estrogen receptor positive breast cancer for primary prevention of breast cancer. So this one could be for treatment of breast cancer or for prevention of breast cancer. And women with high risk of breast cancer, if she has a family history of breast cancer. So we can use the tamoxifen for treatment of breast cancer or prevention of breast cancer. What they found here, the tamoxifen increased risk of endometrial cancer, uterus cancer, and estrogen or tamoxifen increased risk of thrombotic complication like clotting. Okay, moving. So now we discuss that tamoxifen estrogen antagonist on the breast, agonist on the uterus and bone, and could be used for treatment and prevention of breast cancer, but there is a risk of endometrial cancer. Regarding aromatase inhibitors, we have anastrozole, letrozole, competitive inhibitor for the aromatase. So this inhibit the enzyme. This inhibit the enzyme here. Okay, tamoxifen considered like receptor blocker. Okay, for the estrogen. Tamoxifen block estrogen receptor. Again. Moving to the aromatase inhibitor and anastrozole, letrozole inhibit the enzyme. So anastrozole inhibit the enzyme, letrozole inhibit the enzyme. And this two type of medication, anastrozole, letrozole, used for treatment of breast cancer. But we need to be sure the patient has estrogen receptor positive. So we need to check the patient if the patient has estrogen receptor positive, not negative. Because if you have it negative, the patient will not respond to this medication. Should be estrogen receptor positive. This group of medication prescribed to the patient with advanced breast cancer following treatment with tamoxifen. If we don't have enough response towards tamoxifen, maybe the alternative will be anastrozole, letrozole. So you can imagine, for example, patient on tamoxifen, but in spite of tamoxifen, the patient starts suffering from breast cancer metastasis. For this reason, the oncologist decide to move and prescribe aromatase inhibitors. Which of the following he should use for the next step? Anastrozole, letrozole. Okay, we're done with the anti-estrogen. So we discussed the first one, anti-estrogen. Regarding the anti-androgen, we have biclotomide. So it's not only flutamide. We have flutamide, we have biclotomide, less of medication. But what we have here, flutamide, and then we have cyproterone acetate. Flutamide, a potent blocker of testosterone receptor. Here we have testosterone receptor. Okay, and biclotomide block this testosterone, block this receptor. So flutamide is like considered like a testosterone blocker, used for advanced prostate cancer, carry the risk of hepatotoxicity. On the other hand, cyproterone considered like inhibit testosterone synthesis, work on the enzyme. This medication has several medical or clinical use. We can use it for male who suffer from hypersexuality, patients suffer from prostate cancer, or in females suffer from severe hirsutism. Male with a hypersexuality, male with a prostate cancer, or female with a severe hirsutism. I will click on the link here. Okay, so I'm not going to discuss the entire information here, But the purpose of this one, NIH, National Library of Medicine, Cochrane Library, you can see here the cyproterone used for the hirsutism, and you can read a little bit about hirsutism as a distressing and relatively common endocrine problem in women. And then we discuss maybe the using of Cochrane Library to figure out the indication of cyproterone or uses for the hirsutism. This is number one. Moving to the next one here, Science Direct. Okay, for the Science Direct website, again, try to figure out a little bit about cyproterone. We have the cyproterone here. Cyproterone discuss about the generic chemistry name or chemical name for the cyproterone. Moving to the cyproterone could be used as oral contraceptive and considered like anti-androgen. You can see the anti-androgen effect of cyproterone and use it for prostate carcinoma, anti-androgen. So we have all these group there. So for the cyproterone acetate. Okay, we're done with this group of medication. Moving to the, so we cover the hormone antagonists. We have anti-estrogen, anti-androgen. Moving to the next group, topoisomerase inhibitor. We have 1 and 2. Again, if you click on this link here, that will take us to the what we have. Moving to the topoisomerase, and we can share it with you. Okay, I couldn't find it, but anyway, I will have to look on the topoisomerase. Give me 1 second. Control F. I think we're done here. Kinase. Okay, so this here from the Lippincott textbook of pharmacology. We have topoisomerase group of medication given IV or IV plus oral. This medication may cause diarrhea, myelosuppression, nausea, vomiting, interaction, and maybe metabolism here. Then we have the side effect of life-threatening for everyone of the group medication. So topoisomerase 1, we need the student to remember we have irinotecan, irinotecan, then we have topotecan. For topoisomerase 2, we have doxorubicin, daunorubicin, etoposide. Here we have chronic myeloid leukemia, pathogenesis, symptoms, and treatment. We have YouTube there. I will click on the YouTube to show you a picture for that, for the Philadelphia chromosome related to the chronic myeloid leukemia.
And welcome back to this U.S. Open.
Okay, now I would like to share with you what we have on the screen. So we have here for pathophysiology of the Philadelphia chromosome, we have a chromosome 9, we have chromosome 22, and then we have chromosome 9 here, we have chromosome 22. You can see we have regular chromosome for both. The chromosome 9, we have a segment called APL, and the chromosome 22, we have a segment called BCR. So in the patient suffer from CML, myeloid lymphoma. So what happened there? What chronic myeloid lymphoma? What we have there? The patient suffer from a translocation between the ABL and BCR. So what we have here, we have translocation from the chromosome 9 to the location of BCR on the chromosome 29. So you can see here what we have. We have a chromosome Philadelphia with a two-segment BCR ABL. So this one, the type of translocation of the gene, this gene is known as BCR ABL active tyrosine kinase. Okay, chronic myeloid leukemia. What we have for this situation, I recommend you to watch this video and understand the pathogenesis, symptoms, and treatment. But for the lecture purposes, we are focusing on the treatment of chronic myeloid leukemia. Okay, so we have it here for the chronic myeloid leukemia, pathogenesis, symptoms, and treatment. Moving to the next group, large group of medication called tyrosine kinase inhibitor, a small molecule used to target signaling pathway of kinase factors such as growth factors. So we call this one growth factors, or sometimes we call this one like cytokine or cytokines. For cytokines, we have more than 60 cytokines in our body. So we have more than 60 cytokines in our body, and one of the most important cytokine, imatinib. So this imatinib here inhibit BCR-ABL tyrosine kinase. For this reason, we use it for the treatment of Philadelphia chromosome positive chronic myeloid leukemia. So which of the following medication used for Philadelphia chromosome positive chronic myeloid leukemia? Imatinib. Side effect, fluid retention and hepatotoxicity. But this is a main characteristic of medication imatinib. Here, students need to understand the situation for Philadelphia chromosome abnormalities and the chronic myeloid leukemia. Which medication we are going to use? Imatinib. Imatinib considered like inhibit BCR-ABL tyrosine kinase. Okay, then another medication here, we recommend you to always click on the link, watch the information. It's required from us. We need to understand, we need to apply it, we need to maybe answer it. Another medication called Victarvi. This medication, Victarvi, and we have it on the website, Victarvi. We have it labeling from the company, then we have the YouTube. So I will click on the Victarvi as YouTube. Okay, I will start to watch the video.
Today, November 28th, glad you're with us. I'm Susan Hendricks, and we start with this. The FDA just approved a groundbreaking new cancer drug that will treat cancer based on the genetic makeup of tumors rather than where the disease originates in the body. It's called Vitrakvi. It comes in an easy-to-take capsule or liquid form too. It also comes with a high price tag. The pill's going to cost nearly $394,000 a year. You heard right. While a pediatric syrup version runs about $11,000. I'm guessing that's based on the dose. While the drug does not work for all patients, doctors say some patients, including children, have seen remarkable results. Dr. David Spiegel, the director of the Lung Cancer Research Program at Sarah Cannon Research Institute, joins me. Doctor, good to see you. So how...
Okay, so you see the video about Victarvi. that target the gene and used for treatment of several type of cancer. That the medication costs more than $300,000 per year for adult and around $11,000 per month for children, available like tablet or like liquid. Let us click on the website and see what is Fictarvi. A little bit of information. We are not going in depth there. So this is the Fictarvi here, and you can see the Fictarvi need to be positive fusion. And Fictarvi, this is a medication here, loratrocitinib. We have the dosing, testing, safety, efficacy. If you need more information, for prescription information, for example, if you click on this one, they give you full detail about prescription information. We have the revised version, and this is 2018 Fictarvi. Recent medication, a kinase inhibitor indicated for the treatment adult and pediatric with a solid tumor so any solid tumor, and this is a characteristic, that have a neutrophic neurotrophic receptor tyrosine kinase gene fusion without noun-acquired resistant mutation, metastatic, or where their surgical resection is likely to result in severe morbidity. So we have here any solid tumor with some characteristic here. And some studies, they said this medication may treat more than 16 type of tumor. Fictarvi. So we need you to go with the situation there and look on the Fictarvi. The same, this prescription with the demonstration, how the medication work. It's available like capsules, available like oral solution. We're done with the medication work on the tyrosine kinase. We discuss only two medication, imatinib and Fictarvi, and the brand name for Fictarvi. Then we move to the brand name Fictarvi. Another group of anti-cancer drugs, we have monoclonal antibodies. Monoclonal antibodies stand for MAP, bind to the specific protein target on the surface of cancer cell or immune cells. So we need you to be familiar with this list of name here. So what we have trastuzumab, we have Herceptin, we have Herceptin as a brand name, trastuzumab, and they found this medication target cell for molecular target will be HER, which stands for human epidermal growth factors receptor. So the target here, trastuzumab, Herceptin. This medication used for patients with the breast cancer and positive HER2 gene. So we target that gene here, or HER2 or HER2 or HER2. Trastuzumab, Herceptin. Rituximab, the target cell will be CD20 protein, and this protein available on the B cells. We use it for B cell lymphoma. Bevacizumab, Avastin, and this is the target VEGF, vascular endothelial growth factors. This medication used for patients from colorectal cancer. Bevacizumab, if you like to remember, we have V here, then we have V here, VE, bevacizumab, Avastin, and target VEGF, and mainly inhibit VEGF. Then we have cetuximab, EGFR. Then we have dostarlimab, Jemperli, BD1. BD stands for program death protein. So this medication, dostarlimab, target the BD1 gene, considered like programming death protein, and used for colorectal cancer. So the last medication used for colorectal cancer, we have bevacizumab, target vascular growth factors. We have cetuximab, target epidermal growth factors. Then we have dostarlimab. Dostarlimab target the programming death protein. And we have D for BD. Then we have bevacizumab for V. We have V here. So in this case, we need you to remember this list. Let's consider all these medication here. If you look on the medication, I will maybe share it with you what we have there. We have MAB. All these maybe share the same suffix. MAB, trastuzumab, rituximab, bevacizumab, cetuximab. Then we have dostarlimab. Okay, well, the first one maybe for breast cancer, for the breast cancer which is HER positive, lymphoma, rituximab, B cells, colorectal cancer, 3 medication, depends on the which one target the programmed death protein, dostarlimab, which one target VEGF and used for colorectal cancer, bevacizumab. So we need students to remember the name of medication, the target, and the clinical use. If you need more information, you can type it there and look on the information there. I will go with you and look on some data. For example, here, I will go with the medication for such as bevacizumab. And the brand name Avastin. Okay, so we can look on the data here for the Avastin, bevacizumab, injectable medication IV use. And this medication used for metastatic colorectal cancer as a first or second line therapy, injectable, single dose vials. We have a list of medication. You can read all the information according to your own time. Okay, let me close it. Back again. So from this table here, we need you to be familiar with the monoclonal antibody used as anti-cancer drugs. We have trastuzumab, rituximab, bevacizumab, cetuximab. Then we have dostarlimab, the brand name, the target, molecular target, indication. We have 3 for colorectal cancer, 1 for B cells lymphoma. Then we have 1 for the breast cancer. Okay, maybe this is an important slide for us. Dostarlimab, the brand name Jimberly. This is an article published in the New England Journal of Medicine. BD, programmed death cells, programmed death protein, blockade in mismatch repair deficient locally advanced rectal cancer. So we have Jimberly here. We have it like injection. Okay, so we have this one, and if you click on the link here, they will take you to the articles. This is the article published in the New England Journal of Medicine. You can read it at your own time about the medication, and they have also they have record there. And you can listen to the videos at your own time. Let me do something here to show you what we have. Okay, now I'm good. I think I can watch the video together with you. Okay, now I'm good. I think I can watch the video together with you. Okay, now I'm good. I think I can watch the video together with you. Okay, now I'm good. I think I can watch the video together with you. Okay, now I'm good. I think I can watch the video together with you. Okay, now I'm good. I think I can watch the video together with you. Okay, now I'm good. I think I can watch the video together with you. Okay, now I'm good. I think I can watch the video together with you. Okay, now I'm good. I think I can watch the video together with you. Okay, now I'm good. I think I can watch the video together with you. Okay, now I'm good. I think I can watch the video together with you. Okay, now I'm good. I think I can watch the video together with you. Okay, now I'm good. I think I can watch the video together with you. Okay, now I'm good. I think I can watch the video together with you. Okay, now I'm good. I think I can watch the video together with you. Okay, now I'm good. I think I can watch the video together with you. Okay, now I'm good. I think I can watch the video together with you. Okay, now I'm good. I think I can watch the video together with you. Okay, now I'm good. I think I can watch the video together with you. Okay, now I'm good. I Okay, I will bring this one here and we can share the video together.
Patients with locally advanced rectal cancer are typically treated with neoadjuvant chemotherapy and radiation, followed by surgical resection of the rectum. However, this approach carries substantial risk of complications and toxic effects. A new study examined whether immune checkpoint blockade, using the programmed Death-1 inhibitor dostarlimab, would be safe and effective in patients with mismatch repair deficient, locally advanced rectal cancer. In this perspective,
okay, so I will stop here and I recommend you to watch it at your own time. So the dostarlimab used for rectal cancer and published in New England Journal of Medicine. A patient now in remission after drug trial. Cancer, maybe it's like the patient recovered from cancer. Now he's the patient cancer free, and this is great maybe news from this medication and for the patients from cancer. Rituximab administered infusion to the patient, but the patient, when you inject rituximab, the patient may suffer from reactions. We call this one infusion reaction for rituximab. So we have infusion reactions. We use rituximab for lymphoma Hodgkin, and we need you to remember this will be target the B cells, CD20, and target B cells. If you go to the table, to previous table, okay, this is rituximab here, CD20 B cells used for B cell lymphoma. Okay, non-Hodgkin lymphoma. Patient may suffer from infusion reactions, and this could be resolved, okay, by slowing or interruption of the infusion of rituximab with supportive care by prescribing diphenhydramine, acetaminophen, intravenous saline. So, for example, acetaminophen to reduce the pain, to control the pain, okay, and diphenhydramine as antihistamine to reduce the allergic reaction. So we use this combination treatment, diphenhydramine, acetaminophen, and intravenous saline. Okay, mechanism of action, we discussed that. CD20 antigen on the B cells. And if you need more information, you click on this one here and they give you how this medication works. Okay, I will go there. And this is a website, and you can see it on the website on ResearchGate. So what we have here, okay, this is the mechanism of action of rituximab. I'm not sure, they don't allow me to write. Rituximab bind to the CD20 on the B cells. This is the B cells. This is the B cells. And rituximab bind to the CD20 antigen on the B cells, lead to the inhibition or like blocking the B cells and leading to the cancer cell death. Okay. Okay, then we move to the next slide. Last slide, I believe. Okay, so we discussed rituximab with a side effect like infusion reaction, how to solve this issue here with the three things. Okay, and if you look on the incidence of infusion reaction, 77% of patients suffer from first infusion reaction, 77%. So if you have 100 patients, 77 patients will suffer from infusion reaction due to the rituximab, and rituximab used for non-Hodgkin lymphoma. Okay, bortezomib, this medication contains boron containing tripeptide, inhibit proteasome function. Bortezomib used for multiple myeloma. Bortezomib induce myelosuppression, inhibit the bone marrow, cause nausea and diarrhea, fatigue, and herpes zoster reactivation. This is an important one here. So when you prescribe bortezomib to the patient, herpes zoster could be reactivate. For this reason here, we recommend patient to receive antiviral prophylaxis if they receive the therapy with bortezomib. So which of these medications contain boron tripeptide? Bortezomib. What of these medication may cause herpes zoster reactivation? Bortezomib. Okay, which anti-cancer drug you recommend patient to receive antiviral prophylaxis treatment? Bortezomib. So we have the information about bortezomib here. Then we have last medication in the group, interferon alpha. Interferon alpha, they found this interferon enhance immune response. So agents that enhance immune response are preferred as biological response modifier. We have, for example, here interferon alpha used to enhance and potentiate the patient immune response towards cancer. So this one called biological response modifier, interferon as an example for that. Okay, thanks so much for you watching, and at the end of this lecture, we cover the anti-cancer drugs from the beginning, as we discussed all the medications. We need this, maybe you to be familiar with the definition of cancer, the leading cause from cancer, common type of cancer, for example, main type of solid and hematologic malignancies. Then we discuss the characteristic of cancer. We discussed the genetic type of cancer. We have oncogene. We have some genes that suppress tumor. Then we discuss some agent considered like positive regulator and other agent considered like negative regulator. Let me minimize the picture for myself here and go quickly with the slide with you. Then we discuss the cell cycle, cancer cell cycle, and we define the medication to the specific and non-specific. We need the student to remember here, okay, which of these medication affect the specific or non-specific according to the group. We have a lot of links here. We need students to click on the links and read the information. What is the purpose? What is the goal of treatment cancer here? What type of cancer treatment do you have according to the pharmacological treatment, the highlight, then the resistance to the anti-cancer drugs. This topic here reminds us with the resistance to the antibacterial drugs. Okay, so then moving to the combination therapy, then discuss the principle of combination therapy, then the protocol of the treatment, rescue therapy, some example here, lacofarine, masna, felgagastrin. So we need to remember the medication name used for what. Okay, chemotherapy, we discuss the side effect, the most important things associated with the anti-cancer drugs, side effect that could be general side effect or specific side effect. Adverse drug effect could be immediate or could be delayed effect. Then we discuss it in general. We have some case study here. We went through the folic acid antagonist, purine, pyrimidine, methotrexate, purine, 6-mercaptopurine, cyclophosphamide, cisplatin. Then we moved to the cytotoxic antibiotic. We mentioned 3 medication here and we need you to remember which of these side effects may be associated with this antibiotic. Then we discuss vincristine and vinblastin. Moving to the paclitaxel for the breast cancer and ovarian cancer. Then we have hormone antagonists. We have to speak about estrogen target or anti-androgen target. And we have several group of medication there. We need students to be familiar with that. What is irinoctan or tobectan? What is otopside? Topoisomerase 1, topoisomerase 2. Then we discuss the Philadelphia chromosome related to the chronic myeloid leukemia. Then we discussed 2 agents belong to the tyrosine kinase inhibitor, imatinib, used for Philadelphia chromosome positive myeloid leukemia. Then we discuss Victarvi. Then we're moving to the monoclonal antibody. We have 5 medication in this list. We need you to be familiar with the name here, the target, and then the indication. Moving to the last one here, Jemperli and the toximab, and the last one with the boron containing tripeptide, bortezomib, and used for the multiple myeloma, but this medication may cause reactivate of herpes zoster. For this reason, we recommend patient to take antiviral prophylaxis treatment. And at the end, thank you so much for listening, and I hope you enjoy and learn from this lectures. As we mentioned, the anti-cancer drugs is like large topics, and we need maybe hours and maybe half day to discuss these topics, but this is a brief description about anti-cancer drugs. Thank you so much and have a great day, everyone.